Thank you very much, Presiding Officer. I note that I'm almost certainly the third speaker in this debate whose naissance predates, of course, the founding of the Health Service. And it's always as well to, when you're talking about redesigning primary care, to think about the process of change there's been. Family tree research is one of my interests. I see death certificates very regularly from the 1880s, even the 1890s, where it simply says on cause of death, old age, senility, decline, decay, no medical attendant. So access to medical advice and to doctors is something that has come in relatively recently. Lloyd George, of course, in 1908 set in process the Act that ended up as the 1911 National Insurance Act, which meant there was a little contribution taken from each wage packet to pay for healthcare. And indeed, to this day, my records and many other people's are still kept in these medical folders, which some of the older GPs still call Lloyd George's, because that's when they were introduced. The Highland Health Service in the 1930s set the pattern for much of the health service. But of course, post-war, the Labour government, probably their greatest achievement post-war, established universal healthcare free at the point of supply. And my father was a GP in that service, retiring in his 70s in the 1970s. The world has changed dramatically since he was a doctor. Now that's the really interesting point. In those days, we only had doctors, hospitals, nurses, dentists, chemists and opticians. We didn't have urgent care centres, primary care, emergency centres, community unscheduled care, nurses, and a whole plethora of definitions which, whenever the patient is exposed to them, they're confused. The world would be rather better, I think, and care would be better if we simply had simple titles that we use with people. And I think I refer to page 64 in the report that we have before us, that says knowledge of who to turn to, what to do in the event of feeling unwell when the doctor's surgery is closed and which service to turn to first. There is considerable confusion because of the complexity that is presented to patients. And perhaps while we need complexity under the surface to deliver the care service, we should look at a little simplicity in how we deliver it and talk to patients about our health service. When my father was a doctor, it was incredibly easy. You just needed to know one telephone number, which was Cooper 3182, and as luck would have it, the Cottage Hospital was Cooper 3128. So if you got the numbers muddled up, you got one or the other, and that was just okay. The world was, of course, very different in all sorts of ways. My father used to write his prescriptions in Latin, so it was tres in diem rather than 3 times a day. And, of course, the quantities were written in Greek, in minims, so you had perhaps deca minims of whatever it was. Fortunately, the pharmacist also spoke Greek. He was a rural doctor, and to this day, rural issues remain a key problem for the health service. I'm fortunate not to know the name of my GP because I have no contact with that person. But I know that in rural areas, often distant from their patients, often isolated from the kind of help that many doctors in urban areas have, we've got to look further out at that. Now, out-of-hours provision, which is something that's been referred to on a recurring basis throughout the debate here, is a more complex thing for the patient. I've actually only, in reading the material for this debate, discovered that NHS 24 is 111. That's what you phone. I didn't know that. Never had to do it. Never had to consider what the number was. I would have previously just looked up my doctor's number in the phone book, but at least I now know that. Out of hours is, of course, the area of the health service with the lowest satisfaction rating. Perhaps that's not too surprising because, of course, when you want out-of-hours care, that is related to a crisis in your personal health, a point where you're less likely to be tolerant, more likely to be critical. you feel that sense of urgency. Now, technology is, of course, helping doctors and helping patients. Nowadays, the health service is asking us all to do some of the health checks. I've just completed one of the regular health checks for those of us of my age, and all clear again, and that's good news. My watch can tell me what my heartbeat is, and I know that I did that just before this debate. It was sitting pretty well where it should be, and the data is already being stored in a server in California, so it could be available to others. But, of course, one of the things that's said in the report is that information about people's health history is not broadly available. Perhaps we should do something very, very simple. Just take all the handwritten notes and scan them in. We're sort of focusing on these difficult things of translating them into words and interpreting them. There are things we perhaps ought to do. But, Presiding Officer, in the last 10 seconds that you might grant me, I think we're doing very well. The quality of care compared to 50 years ago and when I was born is incomparably better. We can always do better. As us old wrinklies get older, we will demand more. That's inescapable. It's just one of the challenges we're going to have to rise to. Presiding Officer.